This is Radio EBM.
Ganesh, when we discussed before this podcast, meet before, you said that you would also like discuss not only the paper and technical issues, but also the general approach in the clinical part. And I wonder, like, even though the C-peptide is quite important clinically and should be utilized more, but it's like actually underutilized despite its clinical like usefulness. So my question is, what do you think are the main barriers to its broader adoption of C-peptide? And I mean, how does your method will help to overcome those barriers?
Yeah, it's not like a widely utilized, but what good that recently he was added, for example, for guidelines, ADA guidelines and C-peptide, there are like a table, if you look, even they provide thresholds, So I think it's good progress that we get in eventually. So, but most of the time for type 1, I'm not physician, but when we get data and when I talk to physicians, most of the times I don't need to do C-peptides. They can look symptomatic, picture patient and other things. And then, but sometimes you have like subtypes, different diabetes, not type 1, type 2, like more exotic, like a ladder. And for these situations, C-peptide can be useful, In other situations, it can be measured like insulin, okay, it's insulin also, because we doing together like a two insulin normal, and then you measure, for example, or forensic insulin. So you measure C-peptide, and then you measure an insulin. And then if it's injected like an insulin exogenous, so you can estimate how much, So C-peptide has their own small niche. It's not like a big, not like A1C. But what's good is also there are like a progress going. It can be also accepted as a clinical endpoint, C-peptide. So it also will be useful eventually. So, and our methods is not really for clinical settings, because mass spec is too expensive for that and difficult to run, But eventually maybe it can be more broader, if you do this kind of pushing standardization. And one of the things maybe it will be more accepted also of standardization.
So basically, you think that key is finding the niche and target these specific niches, not just making it widespread, broad test, but kind of say like, hey, this is the recommendation. Use C-peptide and our method in this very specific disease with this clinical approach.
Right. Not our method, because it's not for clinical. It's just, but I mean, just analyte, yes. It just, there are like, I see there is progress going, so it's maybe more widely will be.
Dustin?
I was looking at the ADA recommendations.
What did they say?
See, I couldn't read them quick enough. But yeah, I was just trying to bone up on them. It's been a while since I looked at them. So what are the things? I mean, I think part of the reason some of these assays aren't used have something to do with pre-analytical variables and things like that. I don't think it's completely assay based. So I do think that it's some of the issue for utility is it's a harder test to similar to insulin. They have stability issues. You have to treat the sample special ways, and you do have a lot of variability, and some of that variability is probably coming from the total testing process. So like, I don't think the assay itself, the standardization, is necessarily going to fix those type of issues. That's more of the clinical side of things. But as we're thinking about, going through and like improving assays and standardizing assays and, the projects for harmonization and things like that. I'm thinking more on peptides, and part of the things I'm thinking about are, they went live with thyroglobulin, and some of the things that they found with thyroglobulin in the beginning is that it didn't necessarily, the mass spec assay, even though it's more accurate and specific to the thyroglobulin, it doesn't necessarily correlate with the clinical picture as well as the original assays. And then they, some of the, and then you have, I see Russ shaking his head up in the corner. So, I think they're important to do the peptide assays. people also have proposed doing things like AST, ALT. Historically, those assays have been enzymatic assays. A lot of the clinical correlation was done on the enzymatic portions of that. How do we go back and like make sure that the new assays have the same clinical utility and are as robust as the current assays are? We have many decades sometimes of information on some of these assays. So what would be the step to like resolve that gap as fast as possible in your opinion?
So which gap?
The gap in the decades of information we have on the old immunoassays or the enzymatic assays. Now that we're trying to transfer them over to mass spec assays, the question would be: do they have the exact same clinical utility? Do they have more clinical utility? Is there more information we can gather from the mass spec and maybe improve things, or is it we're taking a step back?
Just talking about standardization, I just give you one simple example. For example, A1C, replicated hemoglobin, and hemoglobin is just not play crucial role but oxygen transfer mostly. So, and it's not like a kind of have less biological variability. Concentration keep pretty consistent. So eventually, if it's like a markers like A1C, replicated hemoglobin, we can expect it can be kind of more universal compared to C-Peptide, for example. C-Peptide or insulin, and also very small, like a kind of, I don't know how to say, like a very small niche compared to A1C, because it's hormones. The insulin regulate our body, so there can be biological variability between one person to another person, individuals. So, and this is kind of extra limitation for standardization eventually, because if there are like a variability, physicians can be like a, they say, oh, I don't need this, like standardization, because I know I cannot rely on that because it can vary, even one day to another day. Another thing's limitation can be, as understood correctly, you said about technological advancements, for example. Now, we have now all this mass spec methods, some advanced, like mostly for cancer treatment, some biomarkers or like another technologies, microfluidic devices, all this like a miniaturized testing, and they go so fast, and sometimes guidelines and the knowledge of the physicians and knowledge of the clinical world can be lagging. Eventually, we always can have this lag between well accepted in the clinical setting and technological advance. This can be maybe even worse in the future. It's going fast. And sometimes company can propose, oh, this is new biomarkers, this is new biomarker. And eventually it can be different kind of biomarkers for the same things, but they're not kind of standardized. And one of the limitation also, I think it can be in the future that companies can be, oh, this is our kind of niche, this is our niche. But if somebody will be controlling them, it can be another thing bad for them. They can say, oh, the US is not good enough. This is why I think it's also when we see more advanced technologies. And then, I don't know, like one of the example, Tyrannos, it's a bad example, but still like companies can produce more. They can give more promises, but they don't want sometimes to give I'm not talking about measure components, I talk about like advanced, but they're not talking about like how to be standardized eventually, Some like advanced, one of the, I remember was correct me if I'm wrong, was from Google. They tried to make lens for glucose measure, and in the eye, they eventually stopped this technology. So can be more advanced more and more in the future. So, or CGM devices, we know they're not standardized, from different companies, the different measurement, what exactly they measure, we still don't know because it's algorithm proprietary, and this can be always the issue with standardization eventually. So, and if you look at technology, and mostly all the clinical assays that we use, some of them I was surprised as a chemist because I came to this world, clinical world. I was surprised some of the reaction very kind of outdated, but they're still applicable to use,
Yeah.
They're very good to use, but to me as a chemist, it's kind of, wow, it's interesting.
Yeah, that's very, very conservative thing. Everyone is like moving slowly.